Hey friends, welcome back to the You Are Not Broken podcast. Today I am very excited to have Dr. Lobo with me today. He is a renowned professor of obstetrics and gynecology at Columbia University, and he is widely recognized expert in women's health, particularly in the areas related to menopause, PCOS, and in reproductive technologies. You have an extensive background in clinical research, have published widely, and I want to amplify your voice. So thank you for coming on the podcast.
Thank you, Kelly, happy to be here.
So how did you get started in research and publishing in addition to being a clinician?
Yeah, so in our field of OBGYN, there are subspecialty areas. And I knew because of my interest in reproduction in general that I wanted to do a fellowship. So that's how it all started. I did a formal fellowship in California, at University of Southern California, in reproductive endocrinology and infertility. And so I am what we call an REI and have been that for years and years. And after my fellowship, I started delving into research. I was in many types of research, but we actually established at that point a clinical trials menopause center back at USC. And this goes back to the 80s, basically. And I've continued to be involved both in clinical research and practice of the whole scope of what we do in REI is reproductive hormones. You mentioned PCOS, everything ART, leading up to that. But also a very major focus on menopause, running clinical trials and so forth. And then I came to New York. I mean, I was recruited to Columbia to be the chairman of the department in the mid-90s, and I was chair for a while. And those years when I was chair for about 7-8 years, something like that, because of administrative burdens, I stopped my clinical trials. I had, passed it on to someone else, but I still continue to see patients and remain active that way. And so, I've been involved in the field. I've been a member of all the major sort of menopause and reproductive societies and written several textbooks and published in this whole general area.
Amazing. What do you think, just diving in on hormones in general, picking PCOS or infertility or menopause, what's like the biggest myth that you think clinicians or women have about female hormones?
I think each of those is relatively important. I think there's, the whole PCOS stuff, which I don't think is your focus here, but it's a whole other area
Mm-hmm.
of misdiagnosis and misunderstanding and knowing really what PCOS is. And so many patients are misdiagnosed and their symptoms are ignored and, on and on and on. So it's lack of knowledge in that regard. In menopause, it's understanding what menopause really is. And then when it comes to hormones, right, interpreting what hormones really are, because menopause in very few women just stops very abruptly, right? There's this whole, what we call perimenopause. It's this whole climacteric, which starts from the end of reproductive function onwards. And there's a lot of fluctuation, right? The hormones are up and down, and it's in a way a moving target. So you get established in menopause. And then for a long time, and we were just off cuff speaking earlier that, because of some clinical trials like the NIH, which were carried out now many years ago, where the message, which was incorrect, got out that hormones are bad in general, it wiped out a whole generation of women to be treated appropriately. And I'm not saying hormones for everybody, but I'm saying just the lack of understanding and the fear. And because of that, people haven't been adequately trained. And so you have a generation of physicians and providers of different specialties that just as soon not deal with it because they just lack the knowledge base to be able to do that. So I think that's, those are kind of like the major areas involved in understanding.
Yeah, I agree. Can you share with us, because you were practicing when the WHI dropped in 2002. What do
Yeah,
you
in
do
fact,
you have a very clear, this is the world before that hit and this was the world in the 5 years after?
yeah. So let me just give you a very brief summary of that whole episode. So hormones have been used for a long time, right? So estrogen was established, it was developed in the 20s really, and was starting to be used in the 40s and 50s. And so there were a lot of women who were on hormones or not on hormones, and it was a little bit abused, right? I mean, in the 60s, there was this famous quote unquote feminine forever, hormones for all women, for, sort of too far the other way, right? But rational, making sense, taking care of women use of hormones was used for a long time, to the extent that there was a fair amount of a database. There are databases of the Nurses' Health Study, Rancho Bernardo in California, Leisure World. There are a bunch of what we call cohort studies, epidemiologic studies of users of estrogen in the past. And when you compared their use to women who never used it, and these were largely women who took it for hormonal hot flushes and so forth, it was very, very obvious that the risks and benefits, the benefits outweighed the risks. Cardiovascular benefit primarily, right? Reduction in cardiovascular mortality and so forth. And so I'm moving forward, back in 92, Deborah Grady was commissioned by the American College of Physicians to do a meta-analysis of all the studies and come up with recommendations. And at that time, it was very, very clear that based upon longevity and quality of life, that use of hormones would actually, if used at the time of menopause appropriately, would actually increase the lifespan of women by 1 to 1.5 years, which in epidemiologic terms is huge, right?
Massive.
So that was the current thinking, and that's back into the early 90s. And then around that time, it was discovered that, it hasn't gone through the rigors of the randomized clinical trial for approval, even though there are some motions towards getting it approved for example, preventing cardiovascular disease. So the first iteration of the trials were secondary prevention trials.
Mm-hmm.
So Steve Hulley and others looked at women. If estrogen was going to be good for heart disease, it should help women who have heart disease. And so the initial trials, which are really poorly designed, unfortunately, in retrospect, Steve Hulley and others did secondary prevention trials, women who have established heart disease. So the average age were women in their 70s already, 67 actually, but we went into 70, 75 women who had heart attacks. And they went on full dose hormone therapy for the first time. And lo and behold, they had more heart attacks, right? So that was the first blow. But before those results were actually published and acknowledged, WHI started. And WHI included a whole span of women from 50 to 75, but the 2/3 of women were not symptomatic women at menopause. They were older women. It was skewed towards women in their late 50s or 60s on to age 75. And it would take us hours to discuss the WHI, but I don't want to insult your intelligence. I know you know it very well. The bottom line that came out was that in totality, there was no benefit. And there was an excess in breast cancer with the estrogen plus progestin combination, not just estrogen alone. Actually, estrogen alone and the estrogen alone trials decreased breast cancer. But the E plus P regimen caused an increased breast cancer. Because of that, and no overall coronary benefit, hormones shouldn't be used. And it pertained, even though they used one regimen, they said it pertained to all hormones, all types, all routes of administration, which again is not true, and to all age groups, which is definitely not true. Because when they looked at their own data, both estrogen alone and estrogen plus progestin, there was a benefit in younger women. And combining those two trials in women up to age 60, the fewer women in that database, which is actually 2 to 3,000 women, there was actually about a 40 to 50% protection, which is what they showed in the epidemiologic studies. And it was also determined that, while the estrogen alone arm reduced breast cancer, the E plus P regimen that actually increased breast cancer was pretty much relegated to those women who were prior users.
Yep.
So it was a longer term therapy for many years with this regimen. And so we've learned that long-term exposure to synthetic estrogens does promote breast cancer. It doesn't cause breast cancer, but if some women, because it takes so long to develop breast cancer, if you have a microscopic lesion, it's promotional. right? It's
Mhm.
ER/PR positive, so it will add fuel to the fire, particularly if you add a synthetic progesterone. So we've
Yeah, I was
definitely
going to say the role of the medroxyprogesterone acetate, right?
made a huge difference because concurrently there are trials in Europe, largely out of France, using micronized progesterone that did not show an increase when you added that as part of the regimen, particularly on a non-continuous basis. And then on the coronary benefit side of things, we know that women 60 and above, particularly women who have had previous heart disease, you do more harm than good, right? That's not somebody who should be prescribing full dose hormone therapy for the first time.
Oral. Are we going to separate that between oral and
Yeah,
transdermal?
but I mean, we can drill down a little bit more, but I think in general, the data at hand, which was all oral, would suggest that that population should not be initiated with hormones for the first time, right? And those
Yeah.
are kind of so no secondary prevention benefit. And in fact, not only does it do harm, but the arteries have lost their ability to respond. Because when you get plaque through a lot of epigenetic and other mechanisms, estrogen doesn't work anymore through any of its mechanisms to reduce atherosclerosis, cause vasodilation, and all the things that lead to a coronary benefit. So
Yeah.
it really has most of its benefit in younger women close to menopause and who don't necessarily have bad risk factors that would preclude its being used. So I think you're alluding, Kelly, to the fact that, safer ways to go in terms of estrogen exposure are non-oral. Oral estrogen hits the liver through something we call the first pass mechanism, incites clotting factors and unknown factors in patients who are thrombophilic, have a risk factor of thrombosis. And most of the initial events of coronary thrombosis, heart attacks, are thrombotic, right?
Mhm.
So thrombosis is a major risk factor, hence also some increased risk in stroke. So in higher risk individuals, particularly even in younger women, non-oral preparations, transdermal type preparations, and you can monitor the type of level you want to get, as long as they're not excessive, are
Mhm.
safe.
Yep.
The other argument is, would you ever use estrogen for the first time in somebody at age 70, who
Yeah.
by
We need to talk about that.
definition,
The
who
boomers are
by
pissed that they missed 20 years after the WHI and they want to protect their
exactly,
bones now.
yeah, exactly. So I mean, there is. In fact, there's an editorial I kind of developed, but I reviewed it for a leading journal that is making the comment that if you really look at the data carefully, older women shouldn't necessarily be excluded if they fit into the right category. And so, nowadays through HA and other things, there are risk assessments that you can do, right?
Yep.
And if a woman falls into a reasonable risk assessment, and she needs it for various reasons, using a low dose with appropriate monitoring and measuring levels and so forth of a non-oral preparation like a low dose patch is perfectly appropriate. And in fact, as you probably know, there's something called Menostar, right? Which is a very low dose patch. It's only 0.014 milligrams. And it's only used, its primary indication is prevention of osteoporosis in older
Mhm.
women. So there is the precedent for that, and it is effective, and there are ways to do it, but you really need to know what you're doing because it
Mhm.
is a little bit more of a high risk situation.
Yeah. Yeah. I see a lot of those women. I'm healthy. I've never had, but I take no meds. I would have been on hormones had they been offered. I was never offered. My biggest risk is a hip fracture. Like I see tons of those women, and within my group of people who chew on this, my understanding of this, going back to the secondary prevention trials, is they had a slightly higher risk. Women with known heart disease, now throw them on estrogen within the first year, but then it evened out with the placebo, and it didn't help them, but it didn't make them any worse than the placebo group. So that's how
Yeah,
I.
it's what we call early harm. It was
Yep.
within the first year and a half. And interestingly enough, in that cohort, if women were already on a statin, they were somewhat protected.
Interesting. And again, that's with oral.
That's with oral. That's
The
with oral.
secondary prevention data is
Yeah.
oral estrogen
But
data.
the big issue though is the benefit side of it. So even if you get away from not having any harm, you get past that early harm and you're in your third or fourth year and you're doing okay, and but you don't have the benefit anymore.
As far
There's
as cardio protection,
only
because
cardiac.
you aged out of the benefit window.
You'll get the mood, you'll get the hot
Bones.
flushing, you'll get the vaginal, you will get the bones, all of that, but you won't get the coronary benefit because the vessels just don't respond anymore. They're receptor neutral at that point. They just don't respond.
Yeah, and we chew on. So let's say that woman's in our clinic. She's 73. She's never had a cardiac event. She's not on any blood pressure meds. She's healthy. She's like, I want a low dose transdermal for bone protection. Let's say that's the story. People will discuss what's the right screening test besides just a heart risk calculator. And some people are starting to get coronary calcium scores. My argument is I don't have any data to show that calcified plaques are a contraindication, given the secondary prevention data that we have. Do you have a strong opinion on what should we be checking lipids, like besides just doing a cardiac?
Women of that age should be having all that anyway. I mean, you should have lipids, you should blood pressure check, maybe CRP, things like that. I don't think. I mean, the business of getting coronary calcium has been sort of a go-to thing for making the decision on statin therapy or not statin therapy. But as you know now, the general recommendation is statins for everybody, which is also a little bit overblown. But I think that the risk assessment is just to make sure that they're not at greater risk than you otherwise perceive. And then have that informed consent decision that I can't do it very much more to prevent your heart disease, but if you do want protection for bone and you want to use, some form of transdermal, and it would only be a transdermal type product, and we'll monitor it carefully, it's okay to do.
Yeah, I love that. I think it gets frustrating when people are using absolute cutoffs in a woman that hasn't had an event, right? A cardiac event. And they're saying you can't have hormones because we found this asymptomatic something, instead of doing an informed consent, saying, listen, we found some risks. Let's try to optimize them. But they're using a black and white, like can't have hormones after a certain scan or lab value. That I don't think data supports being that black and white.
Right. And in fact, the data doesn't support not giving it to anybody, which is some people's perspective as well.
Yeah. It's an interesting conversation, right? Because we the experts never want to say hormones for everybody, but then we can also say most people are going to be pretty safe given the informed consent discussion.
Right.
For a low dose transdermal.
You have, as you well know from practice, there are, like all things in life, there are extremes in both directions, and you do have some women who really do need hormones, but because of the fear instilled in them, they don't use hormones and won't use hormones, and rather, they'd rather get a heart attack than use hormones, and particularly breast cancer, which is a major fear women have, which I understand, but so you have that population that you have to do other things to help support their from lifestyle variables to diet to exercise to things to support their bones and other health. And then you have the other candidates who are on the extreme that you suggested, some who would be good candidates, but some who are really, really women who have lots of comorbidities who you just shouldn't go there. And so you have that spectrum. I mean, I've had women much, much older who refuse to get off birth control pills way back when. I mean, it's just that's the spectrum. It's
yeah. Everybody, I think especially in my world of trying to educate, it's a complicated topic, right? Are we talking oral, transdermal? Are we talking synthetic estrogen? Are we talking estradiol, right? There's so much to it. And then on, what I see on social media, people are like, just give me the absolute best dose, best level, black and white. And it's like, no, that's not what the practice of medicine is ultimately.
No, it is very individual, right? Yeah. There was an old review article many, many, many years ago sold that was entitled "Flexible Prescribing," And that's the name of the game. I mean, you just need to, and to this point, this is something that a lot of physicians don't know because they haven't been educated sufficiently in this regard, is that unlike oral, right, which oral for a young, healthy woman is perfectly fine. I don't want to belittle that in any way. I mean, there's a lot of evidence. In fact, all the epidemiologic evidence of benefit is with oral, right, in younger, appropriately treated women. But when you use a transdermal product, and again, transdermal of whether you use estrogel or Divigel or Climera patch or Vivel dot or any of those products, the absorption varies considerably. And whereas with oral, we don't advocate measurements because, again, it hits the liver and you get a whole slew of metabolites, estrone glucuronide, and so forth. And most commercial assays cannot determine accurately what your level is. And most of it is estrone, and its conjugates, it's not estradiol. Okay. But with estradiol, you're giving estradiol, right, with the patch. And you can determine what the level is. And a big unknown is that for a given woman with a given patch, you assume it's going to be at a certain level. Like a 0.025 is a low dose patch, 0.05 is like a medium dose patch, and so forth. Some of those women with that patch, some will be too low and some will be way too high. And particularly when you're trying to manage their endometrial development and how much progesterone they need and so forth, you need to know at what level your estrogen is. Right. And you don't want to be too high, and you want to be, and particularly in older women, you would be much more conservative with keeping the levels, at or below, say, 20 or 30 picograms, as opposed to somebody who really needs it for hot flushes, where the values are more like 50 or 60 picograms per ml.
Yep.
So that is something that, some people, I do a lot of blood measurements, but I think the common provider of non-oral estrogen does not check a blood level.
Yep.
And it does make a big difference.
I agree. And I think, to me, the blanket statement of, oh, if your patch is 0.05, then you better be on 200 milligrams of oral micronized is like, but we don't know what the blood level is. How can we say that it's a dose that requires a higher progesterone versus a level that requires a higher progesterone?
Yeah.
Do you have thoughts on that?
Absolutely. In a given woman, 50 could be 25 or it could be 75. So, and it's been documented. I mean, there's literature on this. There are women on a 50 microgram patch that have 200 picograms per mil of estradiol circulating. And I've had women also where the levels are, they don't feel better. It hasn't helped their hot flushes. And you do a blood level and the estradiol level is almost undetectable.
Yeah. I have a
Just
young
not
woman.
absorbing it, and it's because sometimes they switch from a generic to a brand to so there are different ways to play with it, but you need to know what you're dealing with before you can, determine whether it's the right way to go.
Yeah. I have a young woman who's on a 0.75 and her estradiol is like 13, and she's still like, I feel like I have no energy. She just feels still crappy.
Yeah, that's not enough.
Yeah, she's young, she needs more. Do you go by for your, and thank you for getting into the weeds with this. It's for the people, like there's so many people who are at our level, like they are going to love this. Is there a blood level where you're like, you need 200 milligrams of micronized progesterone to protect the uterine lining? Or how should people navigate when you need enough micronized progesterone?
Yeah. So from a safety standpoint, the first thing I want to know is the level, right? So because you want to eliminate the 200 picogram ladies and get them on the right dose. The appropriate dose for women who have hot flashes is kind of like a 50, 60, something like that. Younger women may need more, but that's a good level. Okay. The second thing, and this is what I do as I practice, is I want to know what their lining is doing. I want to know what their endometrium is doing. And there's some women, even with an adequate amount of estrogen, like 50 picograms, that don't proliferate very much, right? And you may only need to give them progesterone every 2 months, for example, if you're prepared to monitor them closely. But there are some women with even lower doses, like 20 or 30 picograms, that within a month, their lining is like 8, 10 millimeters, double thickness. Where it becomes a big concern. And there are some women, progesterone, as you well know, it's not well absorbed orally, right? So
Mhm.
circulating levels of progesterone are not great. And so the length of time is important. So it's at least 12 days or so. But there's some women who actually need a little bit more, or in some women where it's very difficult to control the endometrium, you have to go to some sort of synthetic periodically.
Yep.
Otherwise, they end up with endometrial hyperplasia, and
Yep.
that's been well documented. So again, very individualized, and you just have to monitor and have the work with a woman to be able to do this.
Yep. I love it. I'm just going to stay in the weeds because I think I love that you can handle these questions. Uh, the endometrial hyperplasia and uterine cancer data, it's old. That was synthetic oral estrogen where we discovered, we need to counteract the effects of the synthetic oral on the endometrium. Let's add a progestin. So that's a standard of care now.
Mm-hmm.
Some experts who know the literature will argue we don't have endometrial cancer data on transdermal estradiol dosing. Do we really need to be harping so hard on a progesterone on those people? Nobody's going to do this study. It would be considered unethical.
Right.
What's your thoughts on that? Because we're extrapolating oral synthetics to transdermal bioidenticals and kind of still having this big fear of needing the uterus protected.
Yeah. So for me, that's a fairly easy answer. I think it's biological. I mean, estrogen is an estrogen. What it does to the uterus is going to be a little bit of variability, but it's going to have that effect. So if you're giving a transdermal product at a certain level, right, as we said, 50 60 picograms, if you give it unopposed without progesterone, you're going to get endometrial hyperplasia. Depending on the individual, it's going to be less or more at a given point. You mentioned bioidentical. It's not as easy to find the literature, but there's 3 or 4 papers in the literature on endometrial cancers because it used to be said use bioidenticals, it's safer and so forth. It's not, particularly with the doses, and there are many cases now. There are at least 3 or 4 papers in the literature showing endometrial cancers in women using bioidenticals. And
Perfect.
because
Okay.
it's been ignored, it's been not monitored, and typically what happens is you're giving a decent slug of estrogen because that's what you want in terms of symptom control, but the bioidentical absorption of progesterone is poor. Because if you're giving natural progesterone, whether it's transdermal or even oral, you're not getting adequate amounts of progesterone for that amount of compounded estrogen. So I think in this regard, the biology is the biology, and I certainly have seen women with endometrial cancer on transdermals who have not taken adequate progesterone.
Good. Nice to get a solid thought on that. So one of my favorite publications that you were part of was a 2017 editorial in the Menopause Journal titled Menopausal Hormone Therapy for Primary Prevention: Why the USPSTF is Wrong. Amazing paper. Do you want to explain, or I can explain, what the USPSTF is, besides very hard to say? And then let's talk about why they said we shouldn't use hormones for primary prevention, and then our opinion about that.
Well, you lead it off, and I'll chime in.
Okay, perfect.
U.S.
So
Prevention Task Force is a very sort of epidemiologic group, right? I mean,
yeah, it's a
large.
group of people
Right.
self-selected who advise, but then Medicare will make payment coverage recommendations on their advice. I know this because I'm a urologist, and I know what they said about prostate cancer screening, and I also know
Exactly.
how that turned out. So the urologists already don't love this group,
Right.
based upon prostate cancer
Make
screening performance.
recommendations on not doing PSAs, on frequency of mammograms and frequency of pap smears and things like that. And some of the recommendations are reasonable, but So the dogma, back to your original question, is that there's no evidence based on WHI for cardioprotection. So therefore, based upon summary data from WHI, it shouldn't be used for preventing heart disease. Okay? So our argument and we have another paper Back to the Future, it's called. It's an atherosclerosis.
Yeah, that's a good one too.
Yeah, which we reviewed. If you really look at the WHI data, and it's separate publications, it's not the whole WHI, where you look at women 50 to 59 or less than 60, and again, this is all with oral estrogen, there was a significant protective effect. And there are data to your point on transdermals, there are data from Tomi Mikkola from Finland on using transdermals, same thing, about a 50% protective effect. And if you look at a Cochrane analysis of randomized trials, which includes WHI of the younger population, there's also a 50% protection event. And so being conservative, when I tease the whole thing like a poor man's meta-analysis, I come up with a 30%. I think it's reasonable. Even the old, epidemiologic studies, very few were up as high as 50% protection. I mean, I think a very conservative number is a point estimate of 0.7, which means about a 30% protective effect. And I think that's reasonable. And even though Cochrane showed 50, if you look at a lot of the other studies and you put them together, somewhere in the range of 30 to 40% protection is reasonable. And so in young, healthy women, and for sake of argument, it's easier if she has hot flushes, she will definitely get that coronary benefit effect, right? I mean, she's 50 to 59, say she's 55, she's otherwise healthy. You will be able, even 5 or 6 years of use, you will get that cardiovascular protective effect, which is primary prevention, right? So the argument is, even women who don't necessarily need hormones for hot flushes, but they're otherwise healthy and they're open to using hormones if it's suggested, I feel very comfortable telling them that our data suggests that you will get a coronary benefit, right? And it's not forever, but if you take it for 5, 6, 7 years, as the younger women in WHI did, you'll get up to a 50%, but more like a 30 to 40% reduction, which is huge for coronary disease, right? Because
It's
it has
huge.
this huge case fatality rate. And then you'll also get benefit on bone as well.
Yeah.
So you
Yeah.
don't have to commit forever, but that is the mode of prevention, preventative medicine. Because if you look at other measures like lifestyle management and so forth, right? The overall coronary benefit for that is in the 13, 15% range reduction. It's half of what estrogen would afford.
Yeah. Yeah. My interpretation of the blanket that everybody should is that's a high bar. We don't say that for baby aspirin. We hardly say it for statins. I'd say statins are the closest to a primary prevention medication that we'd use. And in my analysis, the number I researched the number needed to treat. I forget what article I pulled it from for estradiol, but number needed to treat for primary prevention for estrogen was about 250 people. Number needed to treat for primary prevention for statins, and I'm not sure if this is sex specific, it was 400.
Yeah.
And if you look at the amount of people on statins compared to the people on hormones, we have it backwards.
Right, exactly. And there are data that my good friend Howard Hodas, and you've probably seen him on some of my publications
Can
as
you
well.
get Howard? Can you introduce me to Howard so he can be on my podcast?
He may or may not do it. I can't promise, but
Okay.
Howard's a great buddy of mine. We've done a lot of things together. But anyway,
Yeah.
he is passionate about the point, and he comes from the atherosclerosis world, right? And he's not a gynecologist, he's not a reproductive endocrinologist, but he says there is really no good evidence for statin use for primary prevention. Yes, so in women.
In women.
In women. For men, yes, right?
Yeah.
And for secondary prevention, yes. But what we're talking about, primary prevention, particularly in younger women, talking about mortality as an endpoint, there is no evidence for its benefit for primary prevention in women.
Yeah.
And most cardiologists will push back on that, but
They will.
if you look at the data, and I've been halfway, right? I mean, Howard is passionate in that regard. He also says that statins increase the risk for diabetes, which it does, but it's not massive.
It's small. Also breast cancer, but it's small.
Yeah, exactly. So, but anyway, so that's that whole part of this. It's not as good as people would make out to. So even if you listen to Howard and you look at some of that literature, which is supportive, um, I think the conclusion is that there's no strong evidence that there's this primary prevention benefit. And
To
yet,
statins.
for statins, for
Yeah.
primary prevention in women, right? And yet there's so much data on the estrogen side,
Yeah.
right?
It's crazy. I feel like, I mean, you and Howard must feel crazy that because the data so much and it's basically screaming at you. Yet here
Right.
we have a world where we're sicker than ever. We're living long, but not healthy. Chronic disease is the number one thing that's bankrupting our healthcare system. And we have something that prevents, not 100%, but it's pretty good at preventing chronic diseases.
Right. Yeah, absolutely. And then you can go
Um,
beyond to talk about bone health and
yeah.
arthritis risk and, on and on and on, lots of other things as well.
I think the other argument's the wrong word, but for primary prevention is the role of hormones on metabolic health and decreasing the risk of diabetes.
Yeah, absolutely. Yeah, so that's that analogy with statins, right? So statins don't have that primary prevention role estrogen does. Statins may increase diabetes. Estrogen lowers diabetes risk, new onset diabetes. So, I think
Yeah.
it tips the scales in that regard.
And 83 million people in America are on statins.
Yeah. Oh, huge. Yeah.
It's huge. Yeah, it's like
Yeah.
of the top 10 medications prescribed in America, 2 or 4 of them are statins. It's a lot. You were writing something. You were talking about, what was this? It might have been a metabolic paper, and I don't mean to put you on the spot, but it's something I had never. We think of FSH or follicle stimulating hormone. We kind of think of it as this benign signal that goes up after perimenopause. It fluctuates, and then it goes up after menopause because it's trying to get the ovaries to give some hormones. But I think we think of it kind of as this like benign flag. And you were talking about maybe there's some role with that in weight gain, or people with lower FSH levels have a higher rate of metabolic syndrome. I'm in the dark on any of this. What do you know?
Yeah, there are a few papers, a couple of papers. There's a basic science paper, I think, out of China, and there's a clinical paper. So women who have higher FSHs are at greater risk for metabolic syndrome and metabolic. There's an interaction with adipocytes and not breaking down fat adequately if you have an elevated FSH.
What's FSH doing? And second
So
question
there
is,
are
what's a
direct.
higher number mean FSH lab wise?
So I think in clinical terms, it's not that interesting, quite
Okay.
honestly. I mean, it's like an epiphenomenon more than anything else. And the basic science behind it is that there are receptors on fat cells, like there are receptors everywhere, and so the FSH interacts in that way, preventing adipocytes from breaking down and so forth. I mean, that's the theory behind it. But in practical terms, FSH is one of those funny fluctuating hormones. It starts going up in perimenopause and stays up until a woman is much, much older. So if you're menopausal, by definition, you're going to have an elevated FSH.
Yep.
So, and targeting FSH is not the way to go, because the amount of estrogen you need to drive FSH down is much, much higher than you would need for hormone replacement.
Mm-hmm.
So it's an interesting kind of like epiphenomenon. It might explain why women, even beginning in the perimenopause, when they start having an elevated FSH, are starting to have changes in body composition and so forth, right? And more fat deposition in the abdominal area, visceral fat, all that kind of stuff. It might explain that phenomenon a little bit more as well, but it is not enough to change prescribing habits.
But you think it's more than, because my question is like, is it causation doesn't equal correlation doesn't equal causation? Is it just an associated finding, or do you think there might be something to FSH?
To me, it's just an associated finding.
It's just an associated finding.
Associated finding that may add a tidbit to it, but it's not the major player.
So many people ask me, shifting a little bit, so many people ask me, and these aren't doctors, these are like lay people. They're like, what level should my estrogen be for bone protection, for heart protection, for dementia prevention? My response is, we do not have the data to be solid on giving that advice, except for the fact we've got data that says you need a pretty low number to start helping the bones.
Right.
Do you think we're going to get that data? Do you think people are going to look at the heart needs a level of 40 post-menopause? Where do you think we're going to get as far as getting a little more specialized on how much estrogen is protective for each organ?
So I think you're right. We don't know. We don't know, and I don't think we're ever going to get the data. You're right in saying that the amount to prevent bone loss is less, right? And we know that from women who have been on Lupron and then replaced with estrogen to prevent bone loss when they're on using Lupron for endometriosis and, other diseases, fibroids, what have you. So the amount is a little bit, 20 to 30, 20 to 25 is probably enough to at least maintain bone mass. It's not going to help that much, but that's the threshold. For hot flushes, huge spectrum, and that's why we will never get data. I mean, there's some women who just take a little bit of estrogen and they get relief, right? And there's some women who need much, much higher doses. My guru in cardiovascular medicine is Tom Clarkson, who passed away. Tom was a person, he was a vet by training, but ran that department in North Carolina for many, many years. He's passed away, but he did all those trials in the cynomolgus monkey, looking at he was the main person that coined the term timing hypothesis, that you need to treat early or you lose the benefit if you treat late. Those are elegant studies done in the monkey model originally. Now, back
Very
to
cool.
Tom. Why I'm digressing to that is Tom was a person who said that for cardio protection, you need 50 to 60 picograms. That was an extrapolation from his monkey data, so I can't tell you it pertains to women, but it follows a scenario that you probably need less estrogen for bone, you need a little bit more for heart, and you may or may not need more for hot flushes depending on the age of the patient and what her individual brain is going to be responding to.
Perfect.
And
And then as far as
cognition is all over the place, right? I mean, that's even, that's a whole difficult discussion in terms of whether there is a cognitive benefit and so forth as well. That's very, very, very mixed data.
Yeah. I'm reading papers on autopsy studies looking at brain levels of estrogen and testosterone, which doesn't correlate with the serum levels
Right.
of the lab draws, right? And so you've got that whole thing of, if we're measuring serum, does that even matter? Because it's the levels in the tissue that matters, which you can't measure when you're alive.
Exactly.
At least for the brain.
Right. Yeah.
Is kind of where I got on that. Your opinion on testosterone?
So, it's gone back and forth a number of times. So I think there are some women who would benefit from testosterone, but it's not everybody. Okay, so the original formulations that were available, the old Ester test, I don't know if you're familiar with that.
Yeah, with methyl testosterone.
It was methyl testosterone. It was primarily prescribed for difficult to control hot flushes, not for sexual dysfunction. And yet we did a trial. That actually I was the primary author on, where we randomized patients to ester tests and the estrogen component without the testosterone component. And there was definitely a benefit of the methyl testosterone. Okay, so there is a benefit in terms of hyperactive sexual desire disorder in a very generic sense. But it's not necessarily for everybody. There are some women who do perfectly well with estrogen alone. And the difficulty we have, as you well know, is that in the absence of something like, ester test, and I don't even know if you can get it anymore.
I think you can, because I know some people who are using it.
Yeah, so it's not a bad product at all. But again, if you want to stay away from oral, and particularly, methyl testosterone hits the liver, all those kinds of issues, although it's relatively safe, there are no good products available in women. They started out trying to get Intrinsa approved, which is the testosterone patch.
Yep.
I never saw the day. FDA just wouldn't have it because they wanted to have long-term data, which was impossible. It
Even though we've been
was
using testosterone in women since the 40s.
right. So
Yeah.
it was prescribed in Europe, but I understand there was very little pickup, so they've stopped even making it available. So
It
what
was
we end
only
up,
approved for surgical menopause, not
right,
regular menopause.
right,
So they're like, oh, it didn't sell much. And it's like, well, you only let the surgical menopause people have it.
right.
So
So
it
it's
was
been
kind of a,
largely, the testosterone story has been largely a regulatory one.
Mhm.
So I think there are women who benefit from it. I do have some patients on it, but it's, again, you have to monitor because since you don't have specific products, if you're cutting up patches or using parts of gels and things, you have a tremendous chance of having an overshoot and having
Yep.
too much testosterone. I mean, the data from Susan Davis and others is that to get a therapeutic benefit, your testosterone level needs to be at the upper range, if not a little bit above the normal range. But
Yep.
you don't want to get into the male range, right?
Yep.
And part of the problem also in this area is that the testosterone assay has been
Yep.
geared to measurements in men. So it's far less accurate in women, but, in the normal range, 20 to 50 or 60 nanograms per deciliter, that should be the normal range. So I think a value of 70 or 80, somewhere like that, would be acceptable.
Yep.
And according to Susan's data, that's probably what you need for a therapeutic benefit. But you don't want to get up to the male range. I mean, that's going to cause side effects and whatnot.
Yep.
But there's some women with even in, status BSO, right, who've had oophorectomies where their levels are even much lower because they no longer even make precursors. They do perfectly fine with just estrogen alone, right?
Mhm.
They do perfectly well. And so that's how complicated the whole brain is. It's, they don't necessarily need it. And yet you have some women who may have even normal, quote unquote, adequate levels of testosterone that feel there's something missing. In which case, I consider what I call a therapeutic trial with all the difficulties of prescribing and so forth. I give it a shot, see if they feel better, as long as we monitor them, and then kind of take it from there.
I love it. That's exactly what I do. I mean, I started out giving the testosterone to the men because I'm a urologist, right?
Right.
So I'm like, these small micro doses for women don't scare me.
Right.
But I agree with all of your points. We don't have a great lab test. We don't have a great reference range on the lab test. We don't, and it's like, we're still we're bloodletting with leeches on this, basically. We don't have a product. We don't know how many androgen receptors you have. We don't know how sensitive your androgen receptors are. Like, there's so many pieces to this
Right.
that
And
we're
there's a
like, here's
lot
a,
of individual variation as well, right? Some
yeah,
women do better than others, right?
totally.
Yeah.
What did, to wrap up, I mean, thank you so much for spending the hour with us. Do you have any advancements that are coming down the pipeline, like anything that's really exciting you in this field right now or things you're working on?
More of the same. I mean, we started the conversation saying education is a big piece, and I think in terms of doing a service to women's health in general, if there's some way that we could just educate the masses of providers out there to be able to take care of women, because no one person, Kelly or myself or anybody, can do it, right? I mean, so that's the main thing. In research, there will always be some other products. I mean, over the last several years, we've been delving with E4, Estetrol, which is a fetal estrogen, but it
Yep.
has some fantastic, interesting things in women. I don't want to get into the weeds on that, but I mean, that's something that may or may not hit the day because it's just a very interesting natural molecule that's evolving. And now it's an oral contraceptive as well. But the menopause
Interesting.
therapy is developing. And of course, we now know we have Vitosa and others and, NK3 receptor blockers to target the areas in the brain that specifically are related to the thermoregulatory. So it doesn't do all the other things we talked about. I mean, I think it does have a role, right? Particularly in women who cannot or should not take hormones, for who are bothered by hot flushes. Having said that, we just don't know long term what's going to happen in terms of overall safety and so forth. It has a role, so that's part of our armamentarium now. But it doesn't do anything for bone, doesn't do anything for heart, doesn't do anything for
Right.
necessarily mood or anything like that. But I
And
think
it's
that's what's
brand
needed.
new.
and it's brand new.
We
But it's
don't have
called
years and years of safety data.
exactly.
Yeah.
Yeah. So I think those are the kind of the things right now. We have, there used to be so much active research in this area, and it kind of just stopped. After WHI, there was no interest in it. All the companies that would otherwise be funding it are shy away because they're concerned about liability and other concerns post WHI, and this is kind of where we stand. We would have had, we would have had much more products and much more innovation had there been some financial backing for this process.
Yeah.
So I go back and say, well, where we really need to start is prevention. I mean, is education, so people can then rise up from there and understand that, yeah, we could do this even a little bit better if we could, right? So
Yeah. Yeah, I think two things. I think the prevention discussion is just starting, and I
right,
think it's a grassroots. I mean, what you're publishing to educate the people who are reading it, but then really grassroots from the women themselves. They're turning 50, they're seeing their parents age poorly, they're wondering what they can do, they're hungry for this information. So I think there is a grassroots prevention because Western medicine, we treat disease. We rarely try to prevent disease. Like, it's really a paradigm shift in the traditional Western medicine clinic to talk about prevention. So I think it's very exciting, and I think it's good. It's driven by the women.
yeah, as it should be.
The doctors are too busy. Like, you really need time to be curious and to learn something new that you didn't learn in medical school, and so to the women coming in, hearing these discussions, they're the ones who are doctor. I've had doctor. They're like, a lot of women are really coming in asking for this. I better learn now, right? And the role of that grassroots change to improve people's lives is fantastic.
So hopefully it's starting.
It's starting. Well, thank you so much for joining me today.
All right,
I
you're
had a
welcome.
blast.
Oh, thank you. I enjoyed it.
Awesome. I'll let you know when this is up.
Okay, take care.
Thank
See
you.
ya.